Hello, everyone. Thank you for attending today's roundtable, Working Together Beyond Your Walls, How Collaboratives Are Transforming Population Health, presented by Conduent. I'm Andrea, and I'll be providing you with a few technical notes before we begin. The roundtable is being streamed through your computer, so there's no dial-in number. For the best audio quality, please make sure your volume is up. This roundtable is being recorded and will be available on demand within 24 hours after the event. Time permitting, we will follow the presentation with a Q&A session. Please submit your questions using the Questions and Answers tab on the left side of your screen. Moderating the discussion today will be Stephen Smith, Senior Director, Transformation, Healthcare Provider Solutions. Stephen has over 40 years of experience in the healthcare industry at healthcare technology companies and consulting firms. His expertise encompasses clinical, executive, managerial, marketing, and consulting, and has earned him a track record working with executive and mid-level management as well as physicians to facilitate team and consensus building and vision and strategic transformation initiatives. Okay, let's begin. Steve, please go ahead.
So thanks again, Andrea. And improving population health does take a collaborative force. So today we're going to talk with three individuals who have assembled and led successful collaboratives. These individuals will share with us their insights as well as some of the lessons that they have learned from their experiences. Lisa Bell is the manager of community benefit at BayCare Health System in Florida and leads the community health needs assessment and community benefit across 15 hospitals within the BayCare Health System in the Tampa Bay region. Lisa also co-chairs the Florida Hospital Association Community Benefit Work Group and has provided primary leadership in the development of a 4-county collaborative of hospitals and Department of Health partners known as All for Health Florida. She holds a master's degree in public health from A.T. Still University in Mesa, Arizona. Jane Chai is a community health solutions expert with Conduent and provides expertise and guidance to strengthen the capacity of Conduent Healthy Communities Institute. Jane has been a leader in the field of public health and community health planning for more than 20 years at various organizations in Southern California. This includes the Public Health Projects Manager for Orange County Healthcare Agency Public Health Services. Jane holds a Master's of Public Health from the UCLA School of Public Health in the field of community health sciences. Ashley Wendt is a public health consultant with the Conduent Healthy Communities Institute that delivers technical assistance and capacity building to hospital systems and health collaboratives in support of their community health improvement efforts. Ashley brings to us over 14 years of public health experience in domestic and international public health work, including the March of Dimes, U.S. Peace Corps, and the United Nations Development Program. She holds a Master's of Public Health from Tulane University. So Lisa, we are so very happy to have you with us today, and I'm going to start with you. As Director of the Community Benefits Department at BayCare Health System, I know this topic is near and dear to your heart. You have also been a leader in building successful collaboratives in Dane County, Wisconsin, that included the University of Wisconsin healthcare system. So as we begin to delve into today's topic, let's start by kind of setting the stage for the discussion. My first question to you is, how would you define a collaborative?
To be here and have this wonderful conversation. The classic definition of a collaborative is when two or more people are working together, they're collaborating, right? But I think the definition works. But for me, the true definition of a collaboration is more about the foundation the collaboration is built upon. Developing a working relationship on a level playing field where all voices matter and are heard, where there is agreed upon purpose, definitely a shared power, and most importantly, trust. I think those are key components. And I think really when you have that foundation and you've built that, I think that's what will take a collaborative from a what if we could work together to a what is happening once we are working together and collaborating.
So, Lisa, why would you say collaboratives are important to us today?
Well, I think there's certainly strength in numbers, right? And if we found out anything about how we can improve population health and health outcomes, it's that working in silos just simply isn't working for us. We're not gaining the ground on health improvement that we could be when we're joining forces together. And so I think there's a lot of very well-meaning people and organizations doing amazing work, but when we're all doing it in parallel, it really negates the impact of the potential on population health. And I think the real magic in collaborations is leveraging the strength of a group of multidisciplinary partners to affect change. It's really the collective impact model and sound public health practice at its best.
So, speaking with you, Lisa, and listening to what you just shared with us a few moments ago, I can tell you're passionate about collaboratives and the results that they are achieving. So let's talk a little bit more specifically about your world with the All for Health Florida Collaborative. So how did these groups come together to form this 4-county partnership?
So we're really proud of the work of All for Health Florida, but the collaboration began to take shape when it became clear that all of the hospital systems and the departments of health in our region were on the same CHNA, CHA or CHIP, a Community Health Improvement timeline. So it was really, from a collaboration perspective, a utopia in a sense, where there was not a better time for us to begin conversations, or a better way for us to begin conversations about how we could work together at a time when maybe we were on different timelines. So this just presented a unique opportunity for us to really think about how we could work together. I can tell you there were many meetings, and where initially where we were all there at the table, and ultimately the CHNA and the CHAs and the CHIPs, that those conversations would come up. And it was always, well, we have to do this, and how are we going to do this? And no real jumping on the gas pedal, if you will, to move a process ahead that would allow us to collaborate. So, and I think another challenge is we had many new organizations with new team members leading their CHNA and community-based work that had not necessarily conducted a full-scale regional type CHNA. So that was a bit of a challenge. But what became obvious, honestly, and it is best practice for establishing a coalition, is that someone or some entity needed to step up and drive the bus, if you will. So somebody needed to just get everybody on the right seat on the bus and start working together. So BayCare, the community benefit team, took that on, and really, although at first it was a little rocky, keeping in mind that all of these hospitals and departments of health had never worked together, honestly, and sometimes liked it that way, overcoming that sense of competition and looking at the value of collaboration was key. And I think, ultimately, in a very short period of time, right about 18 months, coming into 24 months of the collaborative together, we do have some successes behind us and look forward to.
So thank you, Lisa. As you kind of reflect on what's been happening with All for Health Florida, what do you feel some of the key outcomes have been?
So I think one of the successes is that even with all of the competing priorities of, again, health systems who traditionally did not work together, we were able to come together behind a single survey tool. I can tell you this was no small feat. It took a lot of time and a lot of patience. We had, again, a children's hospital, a cancer institute, other large health systems, all trying to, get what they needed, and at the same time form a collaborative through the single survey. But in fact, we did get to that point, and from there, I think one of the critical first steps in a collaborative is gaining that first win. And from the survey came our very first win. And typically, community health surveys in our regions have yielded 400 or 500 responses, community responses each year. And you sort of got what you got. You put it out there, and maybe got 400 or 500 people to respond to it. With our collaboration, our work resulted in just inside of 20,000 community survey responses. So, as you might guess, it yielded extremely robust data for us, and along with a really strict methodology that we were able to put in place to assure representativeness. So not only was it just go out and get what you can get, but we worked really hard to make sure that the responses that we had were representative of the communities. And I think that elevated the sophistication of our work and the respect within the communities of the collaborative process as a whole. And then from there, without Conduent's support, we wouldn't have been able to really achieve those levels of success and sophistication from a representative perspective. Gaining that data that they were able to provide us so that we could benchmark and really go after populations who were underrepresented to make sure that the end result was stellar and strong and representative, and we were able to do that. So it was a big win for us and for the communities that now have access to that data.
Very, very helpful, Lisa. Hey, Jane, I want to turn to you for a minute. So I know you're currently part of Conduent's Community Health Institute, but you also once led community health initiatives within the health department in Orange County, California. So when you think back on that experience, and I know one of those collaboratives included several hospital systems, tell me a little bit about your experience.
Yeah, thanks so much for the question. When I was at Orange County Healthcare Agency, which is our name for the health department here in Orange County, California, I did have the opportunity to help launch Orange County's Health Year Together. That's the initiative we called for. It was an initiative to improve health and well-being in Orange County. And the health improvement partnership behind that, as you mentioned, included many of our hospitals, and also our universities, our school districts, businesses, as well as community-based organizations. So it was a true collaborative that brought different partners together. And as Lisa mentioned, I think really the impetus was that many of us knew we were working on different plans, and we're trying to do similar things, but in parallel. And we wanted to just align those efforts and be as efficient as we could with what we were doing. So we began by looking, as you often do, and as Lisa was talking a bit about, by looking at a common set of data. And we too used Conduent Healthy Communities Institute's platform for looking at the data. And what looking at the data at a community level allowed us to do was really identify that we, in fact, something we knew in our gut was that we were working a lot with the same communities. But when you looked at the data, it became really clear that disparities that you see in income and education and in housing were the same disparities that you're seeing, or in the same neighborhoods as you're seeing for obesity, diabetes, and other chronic diseases. So it had allowed us to identify some shared priorities that we could work on together, which is really the goal of a collaborative, is, where can you align your efforts? which is what we did. So as the health department, we worked on programs like resident leadership academies that trained residents on how to look at health and advocate for their needs. Hospitals implemented chronic disease management programs in those communities. School districts were implementing school wellness policies in districts they knew that were in schools they knew were at higher risk for obesity or diabetes. And one of our big wins, as Lisa mentioned, was actually receiving a $4 million grant from the CDC. One of our community-based organizations received that grant to implement an active transportation program in some of those communities in Orange County. So it was a really fantastic way to, really align the data with what we were doing. And I should mention, consequently, the data allowed us to identify that some of our higher income neighborhoods, so we call South and coastal Orange County, were actually at higher risk for mental health issues, like suicides, hospitalizations due to mental health, as well as substance abuse issues. So again, hospitalizations and death rates. So it got us to work on some collaborative efforts in those areas as well. So I think having that collaborative effort really allowed everyone to come together, look at the data, and figure out what piece of the puzzle we can work on to move the needle.
So I sit here and I think about what Lisa has shared, and I synthesize some of the thoughts you just put on the table. It seems to me that it's safe to say then that collaboratives can be a win-win for both hospitals and public health systems. So, with that being the case, why is it that we don't see more of them being established? Do you think there may be some challenges or other roadblocks that we all need to be aware of that might be getting in our way of setting more of these up?
Yeah, this is something I spend a lot of time thinking about. And I think I've come to a couple of things. And one of them I've talked about, which is the data. I think because of our professional backgrounds or educational backgrounds, we often talk about similar problems, but in different ways. So someone in education might talk about lower test scores. Hospitals might talk about, higher readmission rates or preventable hospitalizations. And, the health department, we talk about overall prevalence. So say childhood obesity rates. So we kind of come at it from different angles and talk past each other sometimes. So I think for us, zooming out and looking at the data from a community level was really key. So having that common data that we're looking at with similar definitions allowed us to identify the problem and also share the language where we could really say, no matter what educational background you have, no matter where you live, what you look like, what you do for a living, you should have the same opportunities for good health, a good education, and living a good life. So I think having that shared data and shared language is really helpful to get past that barrier of working together. The other thing I think is the idea of incentives. And I think this is definitely changing, but for a long time, particularly, I think our healthcare system was incentivized to work on a fee-for-service basis. And that really incentivizes working in silos because you're doing your thing and you're getting, paid based on that. But as Lisa mentioned, real change in terms of outcomes, health outcomes and otherwise, really happens when you work across sectors. So when you look across all of these different disciplines and different organizations so that to come together, and that's how you really move the needle. So I think as we work towards, and we're seeing more performance-based reimbursements, we will start to see folks working more together. And we're definitely already seeing that as really treating the whole person and the whole community rather than just working in our silos and, seeing what's right in front of us.
So, Ashley, this kind of brings me to you. You're a consultant who works with both hospitals and community health organizations to build collaboratives. So, I guess my first question to you is, do you agree with what Jane is sharing with us about the lack of unified language, data, and incentives as being a challenge? And then, I guess, second of all, as you think through some of the challenges that your clients in the form of hospitals and community health organizations have had as they try to leverage their data in decision making. What are your experiences in that regard?
Sure. Thanks, Steve. I have to agree with what Jane was sharing. We often see individuals and populations we serve in different ways depending on when or how they're engaging with us. And this leads to that lack of common language or common data that Jane was referring to. But when we look at our healthcare systems, they are increasingly motivated to see their patients from that whole person care perspective. And I think this is an important shift towards preventative care instead of the reactive care that has historically driven our systems. And I think the Affordable Care Act has been a big factor in this, and has given systems and clinical providers more incentives and tools in their toolbox for providing that holistic care. But I think the challenge is people live and work in a world far outside the clinical setting, and there are social and economic factors that are influencing an individual's health or community's health. And these can influence their quality of life, how long someone's living, as well as other things. But we're also learning that our health really starts where we live, where we work, where we learn and play, and factors like our economic stability and access to quality education or affordable, healthy food are just as important as that access to healthcare. And we really can't expect to shift our focus of care without understanding this bigger picture. I'll also add that while we're capturing more clinical data than ever before, there is a lack of comparative data that complements these clinical outcomes with population and community data. And this data is important so that we have a greater understanding of where our patients or even our potential patients are living their lives. This would allow us not only to identify people who are returning to the hospital at higher rates than others, but also to understand exactly where within the community these patients are living their lives and what may be going on there that could either help or hinder their health. And really correlating public health data to identify these social determinants of health will ultimately assist in providing better, more whole person care.
So, Lisa, as we sit here and we think about what Jane and Ashley have shared with us, kind of wearing their consultancy hats, how does this compare or contrast with your experience?
So I really have to agree with Jane and Ashley, on looking particularly more holistically. From a health system perspective, we are doing a lot of work to really address social determinants of health, much more than we've done in the past. And I think having data to drive that is critically important for us. And fortunately, I think for the All for Health collaborative, we were able to get very robust community data, right? 20,000 responses is going to give you some really strong snapshots of communities. And, this positioned us to utilize these data exactly as Ashley mentioned, kind of drilling down into individual communities and looking at where people live, work, play, pray, and raise their children and their families. So the survey intentionally addressed emerging health issues like social isolation, adverse childhood events, housing, food insecurity, in an attempt to really get a better look at what communities were really struggling with. And, from a BayCare perspective, we took these data and predominantly used our ED and hospitalization data to drive implementation plan interventions. So that said, though, when you're looking at data like we had, the collaborative was able to also really work with community partners to identify gaps and enhance their work. For example, we're working with a local community college who's really interested in understanding more about their underperforming students and some of the challenges that they might be facing in an effort to keep them in school. And we were able to take a lot of our data and overlay it with theirs and give them a really strong picture of the potential barriers that many of their students are facing. So it was really valuable. But that said, in and amongst the collaborative, I would say we do have a significant gap in the structure of being able to share some of that same data that I have access to through my health system more broadly across the collaborative. But, it's still very much a work in progress. The intent is there, and which is great. But I do think that using Conduent's Healthy Communities dashboard as a set point has provided consistent data and up-to-date data that we can turn to as a collaborative to begin to work together around some of the data points that we're all interested in.
So, Ashley, I'm going to come back to you. I perceive that there could be a data integration challenge. Maybe I would even call it a problem. How do you think we might solve for this?
Sure. Historically, from our perspective, we've worked with health departments and community benefit divisions of hospitals and health systems, as well as the collaboratives we're talking about more today, supporting their work and their strategic decision-making processes with our population health data platforms and tools that Lisa was mentioning. And these population health platforms really allow communities to explore key health and quality of life indicators from national, state, and even incorporating local data sources. We also offer complementary tools like our Socio Needs Index that incorporates social and economic determinants of health that are associated with poorer health outcomes. And together, these tools can be used collectively for improved and more targeted decision making and planning to improve overall community health.
So, taking that and then kind of contemplating what you've encountered with working with some of your clients, can you give me a little more specificity or information as to how you've been working with clients to address these concerns or questions?
Sure. Just to elaborate a little bit more, in response to the changing needs of our clients, we've really been working hard to integrate the community data that we already historically work with more up-to-date real-time clinical data to provide that more holistic view of patient and community. And in combining this clinical and population health data, it really moves us more towards that goal of providing preventative care instead of the reactive care. And as we've talked about, there's only so much we can really do for a patient in an emergency room setting or in the doctor's office, but really having that ability to move your perspective and view and care beyond the hospital walls into their home, into the community, there's really so much more we can do. And I think layering in community data provides a more holistic, data-backed, informed shift to provide that perspective and ultimately improve care. And I think in creating this shift, we're really reinforcing the idea and need for collaboration. And that's really the emphasis of what we're talking about today. A provider sitting in front of a patient trying to understand her broader needs for safe housing, for example, that won't exacerbate the asthma that's bringing her into the ER multiple times a year, may really feel paralyzed because they don't feel they have the capacity or the resources to really address her needs. And in this particular scenario, that clinical provider really needs to rely on collaboration with other partners and tapping into resources beyond the halls of their hospital to truly address the needs of that patient. And I think in doing so, they're not only impacting the life and health of that individual, they're also reducing the number of times she's coming into the ER, and that can improve or impact overall cost to the system. And I think this is where collaboration really takes meaning. We want to be able to care for the individuals outside of these acute care events and really bring systems and clinical providers into the fold with the support and resources of a collaboration that is backed with data-driven decision-making so that we're all able to come together and meet our goal of transforming population health.
So thank you, Ashley. I think this brings me back to you, Lisa. So we kind of started today's discussion with you sharing some of your successful experiences with building and leading collaboratives. And then we garnered some input regarding some of the challenges and how we might solve for them from Jane and Ashley. So as we approach the end of this kind of formal discussion and open the line for some questions, there's a couple more questions I have for you. So let's think about 2021 and what is next for All for Health Florida Collaborative. What are you looking forward to in the next year?
So this is such a great and timely question. So thank you for that. But, I think we're all ready to rush out of 2020. And I think as we look into 2021 as the collaborative, we are armed with a lot of data to work with. And at the same time, looking a little bit deeper into 2021, preparing to begin prepping for our 2022 CHNA data collection. So, I think I think, however, that the changing environment will require us as a collaborative and as health systems to continue to pivot and be responsive and nimble. I think, for example, the collaborative went out in this past summer in July and August and resurveyed our key informants from our 2019 data collection just to get an idea of what the communities and individuals that they serve and are engaged with in the height of COVID, what they were seeing, what they were experiencing, and had what they told us 18 months ago, had it changed dramatically? And that the data that we got back was compelling. Our challenge going forward is certainly that we're going to need to be able to address issues that are emerging that are much bigger than they were, 18 months ago, and using data to really leverage that change. And I don't think the impact of COVID on communities can be overstated at this point. We will, as a collaborative and as a community and as individuals, be grappling with how to address increasing need far past 2021. I think 2021 does present us with an opportunity also to address the more difficult issues we face when looking at improving population health, and those around health equity and social justice and racism. I think it will be imperative for the collaborative to be leading and potentially funding these community efforts. I think we need to be a voice in the discussion, but we also need to be the ear and to truly listen to our communities, the needs of our communities, what we can do as health systems and collaboratives to help, and most certainly lead by example.
So, Lisa, you are a wealth of knowledge and experience, and I think I would be remiss if I didn't ask you if you have any parting words or advice or anything like that you can share with all of us that may be considering a similar path or just simply starting to develop a collaborative. What sage advice might you offer?
So, thank you for saying that I have the voice of wisdom. I think we're all in this together. I would say that collaboratives are a great opportunity to improve population health. I'd say too that they're not always easy, but the end is worth the means in getting there, essentially. I think, when you can be open and work with other organizations toward a common goal, I just feel like the collaborative process in and of itself brings people, individuals, and communities together in a way that nothing else that we could do does. And it kind of goes back to my favorite quote from Margaret Mead is kind of led my work for a long, long time. And, I think she said it right when she said, never doubt the power of a small group of dedicated people to change the world. And in fact, that's the only thing that ever has. And I think that's really the genesis of collaboration.
Good counsel. I want to thank you, Lisa and Jane and Ashley, for sharing all of your perspectives. I think it's been helpful information, and I perceive that it probably has spawned some questions. So I'm going to now thank each of you for this great discussion and hand the mic to Andrea.
Of course.
Thank you. We will move on to the audience questions now, and there's still time to submit questions using the Q&A tab on the left of your screen. We have a lot of great questions already, and we will try to get to as many as possible. The first question here is, do any of you have examples of how collaboratives are thinking about higher vaccination rates as the COVID vaccines are coming soon?
So I can jump in and just tell you what we're thinking about at the All for Health Collaborative. We're certainly looking and started several months ago to really do a large-scale campaign around the flu shot. More specifically, in order to get the information out as a collaborative, kind of fanning out within our sphere of influence to engage communities. We were very successful in drive-by COVID testing, so we've incorporated the drive-by flu shots into that mechanism there. And really reaching into more of our high-risk communities where there is clear and evident and reasonable distrust of the health systems, and then some of the more politicization of the COVID vaccine, to kind of try to make sure that people understand that this is a safe option, and we are, as health systems and departments of health, should be your trusted organization to turn to ask questions and get vaccinated.
And I'll just add, I think I agree with what Lisa's saying. I think health communication is a really big factor in all this. We've been implementing a lot of focus groups and key informant interviews with our clients this year in their communities, and in the conversations that we've been having around COVID, a lot of community members are just voicing concern around, misinformation, not really knowing, who that voice of authority or reason is related to all things COVID. And I think the vaccine is a big portion of that because of the way it has become politicized and can be very polarizing. And so I think there's really the opportunity to, leverage solid and straightforward and clear communication campaigns now from the public health side, while we're, laying the foundations of being able to roll this vaccine out. And Jane, I'm sorry, you were about to speak too.
That's okay. I think I was going to say a lot of the same things, but one thing I know, I'm still doing some work with the Orange County Health Department, and I think the collaborative there is really interested in looking at from an equity perspective, because as Lisa mentioned, some of the communities that are hardest hit by COVID may have some of the deepest mistrust of government. So I think this is where collaboratives really come in as an important piece of the puzzle, because within your collaborative, you have many trusted partners by the community, and you can really leverage those trust relationships to do this messaging on behalf of the health department, where maybe there's been some lost trust with the health department. And I think, again, we can't overstate enough the role or the lens, that health equity lens that we need to apply upon COVID and the vaccine. And I think, again, that's where the collaborative does a really good job, because you have a well-rounded group of people that hopefully also represent the community and can echo those voices that may not be heard.
Yeah.
Thank you so much for those answers. We have another audience question. An audience member who is located in Central Oregon and has done a regional health assessment and regional health improvement plan for 9 years now. They're on their third cycle collaboratively, and this is their question. How do you address your partner's desires to track and drive data that may not necessarily be tracking within Conduent HCI?
Yeah, this is Jane. I can go ahead and speak a little bit about that. I think we too were on our about third cycle in our planning process, and one of the challenges, I think, is that some of these outcomes that we're measuring takes time, and the community health data that we're looking at are these larger community health data, so median household income or rates of diabetes. So those changes don't happen over a year or two as you're building your collaborative. They happen over maybe 5 to 10 years. So in between that, I think this is the question is, how do you track those outcomes or the things that you're doing that are in your plan that don't necessarily show up in community health data, like rates of diabetes, so that's maybe 5 to 10 years down the line. And within Conduent, we've really heard that among our clients, and we do have a strategy tracking solution and folks that can help with that, where we're looking at the intermediate outcomes. So things like the process outcomes, as we say it in public health. So, the classes that have been conducted, the number of people who've been reached out to, whether you've seen some type of knowledge or behavior change. So those are things that we have been tracking over time to make sure that we are headed towards our mark. Because, if your model works well and you think that diabetes, for instance, could do well with more school wellness policies, then you might track the number of schools who've implemented that. And as an example, in Orange County, that's actually what we did. And we went from having 0 schools in America's Healthiest Schools, I think, being ranked as an award, to having many of our schools within the school districts with the highest disparities. I think almost half of California schools that received that award actually were in some of those districts, because we worked to identify that and work to do something about that. So for us, it was really identifying those intermediate outcomes and then tracking those over time. And that's something you can do on our platform, but there are many other ways that you can do that via reports or Excel sheets.
Thank you. This next question is for Ashley. What have you seen as a major contributing disconnect for hospitals to translate their health improvement strategies into the community?
Thank you. And I think it builds a little on the topics that Jane was just speaking to in the previous question. I think a big part of it is ensuring that you are putting together realistic strategy plans. I think early on in the cycles, when hospitals or health departments first began implementing these community health assessments, we saw clients throwing everything but the kitchen sink into these plans. And over the 3 years working with our partners, it was really difficult to implement and evaluate and track the success of these programs. And so we really worked with our clients to ensure that the plans that they're putting together are meaningful and really in alignment with the health needs that are coming to the forefront of their needs assessment processes. If they're working in a collaborative setting, to ensure that the components that are being put into that, there are different layers that the collaborative partners can participate in. I think being able to set process outcomes, as Jane spoke to, as well as longer term outcomes, are really good too, using the data that's available to set those benchmarks, to set those baselines, and then thinking creatively on how you can measure those process and outcomes as you move forward. And I think the other big component is just ensuring that you bring everyone to that planning table and conversation from the very beginning, not just showing up at the end once you've put everything together and expecting everyone to support and buy into what you put together. If you bring them to the table at the beginning, help them understand the decision-making process and the method behind the madness, I think it builds trust and support for the plan early on.
Thank you, Ashley. This next question is for Lisa. What are your top 3 pieces of advice to hospitals and health systems for sustaining their impact outside of their walls and into their community for the long term?
So that's a great question. I think first, my very first piece of advice would be to find like-minded or not like-minded organizations and collaborate. Obviously, that's the key to any long-term sustainability. I think too that we often have a tendency to look at the data and and understand it, and we know evidence-based practice, and we know all of this stuff, but we're maybe not as aware of what that community specifically needs. Maybe we're not listening as much as we need to. So I would say my second piece of advice would be to really listen. And I use a quick analogy of, we see a community and I do a ton of GIS mapping and really drilling down into communities, and I'll go, there's a huge hotspot here. And, you kind of get it that I bet, it's looking like there's a lot of, people carrying too much weight in those communities. And I bet they'd love Zumba because I love Zumba. It worked for me. Let's bring Zumba into this community. And we are well-intentioned, and we run into this, this neighborhood with community center with Zumba, and they look at us like, you don't listen. You're not paying one bit of attention to us. We need walkable streets and fresh fruits and vegetables. We need grocery stores, right? And so I think it's critically important for us to listen. And then finally, I think, really making sure that the work that you're doing is meaningful and impactful, will be that key to long-term sustainability. So if you have your community involved, you're listening to them, and you're working with programs and projects that are designed to improve pop health long-term, then you've got the key ingredients to sustaining that work outside the clinic walls.
Thank you. This next question is for Jane. Can you please touch on some reasons community organizations have moved forward with community health without hospitals or health systems leading the charge? Essentially, why might community health organizations be weary of hospitals if that's ever the case?
Oh, that's an interesting question. So let me just think about that. So essentially, why might community-based organizations that are looking to do this work not invite their hospital partners along. And I think there might be a couple of reasons for this. I think Lisa mentioned earlier at the top of this that sometimes if those trust relationships aren't built, then that might be a little barrier to getting things going. And from what I've seen of community-based organizations and the collaboratives that they tried to build, a lot of times I think they're focused more on social determinants of health, as we would call it. So things like food insecurity, adverse childhood events, or income or education. So they're looking at the things surrounding health. And sometimes I think there might be a fear that if you invite a hospital, or even in our case, a health department partner along, that their sole focus will be on health, and it might derail the process. And I think that's where, again, having that common set of data where you're looking at a community across their different data, it really helps build common language so that you can say, even if you are the hospital or the health department, we can work together on things that benefit, each of our organizations in the way that we want to, or hope to. And I think the other thing is, and this is, I think, a national experience, is that many of our hospital systems are part of larger, maybe multi-state systems or national systems. And sometimes there's a fear that if you invite those partners in, that they might not have that local perspective, and their agenda might not be as local as you'd like it to be. And again, I think that's where local data really matters. So looking at the data at the neighborhood or zip code level helps you identify that even though maybe obesity or opioid abuse is a national priority for the hospital system, you really learn where you need to act when you look at the data at a more local or hyper-local level. So I think that's where some of the fears might be from community-based organizations, and some ways that you can really address it is by looking at the data overall and also taking a more in-depth look at the data at the local level.
Thank you so much for the answer to our last question. We had a lot of great questions today and could not get to them all, but we will try our best to get back to everyone who submitted personally after the event. Thank you for attending this fierce healthcare roundtable and submitting so many great questions. I'd like to thank our speakers for participating and Conduent for presenting today's event. This roundtable has been recorded. You will be able to access the recording within 24 hours using the same audience link that was sent to you earlier. Thank you again for joining, and we look forward to seeing you at future events.